Hello, my name is Alex Bardakh, and welcome to AMDA on the Hill, our periodic update on AMDA's work on policy and advocacy. Obviously, we're nearing the end of the year, so what I wanted to do this time around is to give you an overview of what happened in the last year. I think it was an important year for AMDA advocacy. We achieved a number of our goals, and then talk a little bit about what we expect to happen in the upcoming year. I also want to thank you all for staying engaged with us. What I'll talk about, some things that we've talked about during these updates. Thank you all for sending questions, for those of you that did, and staying engaged in our advocacy efforts. Obviously, everything we do would not happen without our members and without all of you staying engaged and being active, both on the state level and on the federal level with us. So first of all, thank you all for everything you have done this year and everything you have done throughout the years with AMDA. We certainly appreciate that. But to talk a little bit about what had gone on last year, I think the highlights, I'll start with an issue that we continue to work on, and that is we really focused on highlighting the role of the medical director and providing transparency around that role and elevating that position. And we've done several things around that. One is that you've heard our Executive Director, Chris Laxton, talk about, and that is trying to work with CMS to publish a public directory of all medical directors in the facilities. There's a number of reasons that we have talked about for that. But mainly we want to make sure that both consumers and the healthcare market know who these people are and the importance they play in their role in nursing facilities. Having said that, this year we also took steps to update, and we finally did so, update our Model Medical Director Agreement. This was a flagship document that AMDA has had for many, many years to help both new and those medical directors who are renewing their contracts with their facilities to help them with a template, to help them kind of guide them how to do that. So this year, given that the role of the medical director has probably expanded a little bit in the new payment models, and given the shift to value-based medicine, AMDA really felt like it was time to update that document, and we did so. We did so with the help of our volunteer leaders who spent a number of hours looking through specific language and thinking about, in very detailed terms, what language should be there. What you'll find if you look at that document is that there are several options for you in terms of what to include and what to think about including in such a contract. And it really has to deal with value-based medicine. What's the medical director role in working with the facility to position themselves to be part of value-based medicine? And with the advent of the patient-driven payment model, what should medical directors be aware of, and what work should they be doing with the facility to ensure that there is success in the new PDPM framework? Speaking of that, our other priority this year really has been to elevate the role of nursing facilities and the clinicians that work in nursing facilities and the post-acute sector in general in terms of being in the driver's seat, quote unquote, in value-based medicine. This has been a challenge, of course. All of those things that have occurred to date really focus on the fact that a lot of accountable care organizations, a lot of bundled payment, first and foremost, they begin with a hospitalization. They begin with the hospital sort of in charge of the whole system. And what we've tried to highlight with CMS, with Congress, is that the role of the nursing facility is quite important, and none of this will be successful without a clinically trained workforce who can participate in the shared savings world in the new value-based models. So we really tried to describe the workflow of a clinician, the workflow that a clinician has with the facility, the relationship they have with the facility, and how we can elevate this field. I think we've been fairly successful in doing that. Of course, there will be a number of steps that will move forward in 2020, but we've been successful in terms of congressional action and talking to the federal government about the importance of that. I will also highlight the fact that we've worked very closely with our partner organizations, both on the consumer side and on the industry side. We've worked with Consumer Voice and a number of consumer advocates. We also worked with the American Healthcare Association and Leading Age and our partners in those organizations to really engage in conversations on how to position this field to be successful moving forward. And like I said, I think this will all continue, but it was a theme throughout. Another theme throughout this year has been, and you've heard me talk about this, no success would happen in the modern world without exchange of data, without robust electronic health records. Electronic health records that are actually meaningful and not for clinicians that simply waste administrative time. We've worked with the American Medical Association, who's done a number of studies, who's found how much time clinicians have been spending with their electronic health records that are not beneficial to patients. And we've really focused on highlighting the need for hospitals to share information with the attending clinicians, with the next site of care in the facility, and home health and others. And so we've taken a number of steps in that regard. A number of our volunteer leaders are serving on panels within the Office of the National Coordinator, ONC, and CMS projects that are focused on interoperability. I will not predict that interoperability will be solved in 2020. But I think this year we have taken important steps with CMS. They've come up with a uniform data element library that will help us move forward some of the challenges that I'm sure you all face in dealing with your clinical records and exchanging data. But it's something we want to continue to focus on. The other aspect of it, of course, has been that we have worked to modernize a lot of the products that we provide. And specifically, our clinical practice guidelines, we recognize that a lot of them are still in paper-based formats that may be difficult at this day and age to implement. So we've continued our conversations this year with the vendors, the electronic health record vendors, to kind of put them in front of your hands in terms of some apps or clinical decision support tools and those types of things that are going to be more actionable than they had been in the past. We also did so on an advanced care planning platform. We signed up with a vendor to push forward our toolkit that was created by our ethics committee around billing and talking about advanced care planning. And I think next year you will see that there's going to be an electronic platform that I think will be extremely robust, and we'll have references to our clinical practice guidelines, and we'll have tips on how to have the conversation. It'll be a clinician-assisted module for talking to patients and their families about advanced care planning. We know that advanced care planning is extraordinarily important to this field. We know that it's positive, has positive outcomes on rehospitalizations and a lot of the things that people are concerned about in value-based medicine. So hopefully you will see a lot of those things actually come to fruition in the upcoming year. And we certainly look forward to that. The other area has been telehealth, also related to health IT, but slightly different. I think we have made steps. Last year at our annual conference, we unveiled a toolkit that was developed with West Health, and it's a free toolkit that people could grab and help themselves implement telehealth in their facilities. We have also continued to work with Congress on legislation that would expand the use of telehealth and provide reimbursement for the use of telehealth in skilled nursing facilities. Likewise, we have worked with CMS and petitioned CMS and asked CMS to loosen some of the current limitations on billing subsequent care codes, nursing facility subsequent care codes that are currently limited to once a month if they're billed via telehealth. We have continued those conversations, and we just recently had a conversation with CMS and received very positive feedback on that issue. And hopefully, again, in 2020, we will see some forward action on some of those issues. I think we've made great strides this year, and certainly if you are implementing telehealth, if you're thinking about some of these innovative approaches, please again let us know, stay engaged as you have been throughout this year. Looking forward to next year, let's flip a little bit and look forward to next year a little bit. I think next year we will see obviously a lot more experience with PDPM. PDPM, of course, began in October of this year, and so people were very anxious about it leading up to October. We've heard some positive results. We've heard some continued angst with PDPM. But as things continue to settle down, I think we will work with our partners at Leading Age and ACA and work with CMS to improve things. CMS has actually reached out to AMDA and asked us to provide feedback on the early results of around PDPM. If you are one of those that has some thoughts, some ideas on how it's going so far, what you'd like to see change in 2020 and beyond, we would certainly love to hear from you. So please let us know on how PDPMs continues to play out. So we'll see how that happens. Of course, next year, as I mentioned, we will hope to again continue to position ourselves to be the leader in the healthcare field and in the healthcare system, and provide importance to both the medical direction, to the clinicians that are practicing in this field, to continue to elevate their importance and highlight that they need to be part of the value-based environment that's currently ongoing. I think those are some of the things we continue to see even up until now, although Congress, as you may know in the news, is focused on many other issues. There are a lot of hearings that are ongoing around nursing home quality. And there's issues around the use of antipsychotics, nursing home abuse and neglect. And I think we will see probably some legislation come out end of 2019 and probably moving into 2020. In terms of some oversight changes, I think some of those AMDA is on board with. I think others we will have to continue to work with the Hill to sort of have them understand the processes and how to incentivize both frontline clinicians and physicians and medical directors, how to incentivize them to do better. We've certainly spoken about that majority of what's happened so far has been around a punitive approach. You've heard probably Chris Laxton, our executive director, talk about the Red Hand Initiative, for example. A lot of those things have been viewed very in a punitive way, but what we hope to accomplish is that we start to work collaboratively with the payers, with CMS, and moving things forward in a more incentive-based payment way. Obviously a tall task, but I think we're up for the challenge. I think with all of your help, we will get there, and hopefully 2020 brings us some of those things. Again, I want to wish you a happy holiday season, and as we move into January, and let's start on a strong footing into next year. And as always, if you have any questions, please reach out to us. We're always open. We want to hear from you. Please stay engaged with us, and we'll continue to grow together. Thank you.